Good afternoon to everybody. I'm Dr. Elisa Frisaldi, and it's an honor for me to be here at the 9th EPI Congress. The title of my talk today is Pain and the Context, and I disclose that I have no conflict in any field within this presentation. As you can see from the overview of my talk, I'm starting with an introduction about how pain is modulated by a variety of contextual factors. Therefore, I am explaining the effect of positive contexts, the effect of negative contexts, the effect of context with positive meanings, the effect produced by the lack of meaningful context, and I'm finally concluding with the clinical implication of these processes and challenges for future pain research. A variety of emotional and cognitive factors, as well as sensory inputs, arise from the context surrounding the pain experience. On one hand, mood and attention to pain might be important determinant of pain experienced. For example, negative emotion can provoke or exacerbate pain and lead to neural changes in different regions of the brain. On the other hand, sensory stimuli such as pleasant or unpleasant odors might lead to different degrees of pain. So it means that all these processes influence pain perception and affect the response to analgesic treatment. Bellint and colleagues, in an article published on Lancet in 1955, referred to the context around the patient and the therapy as the whole atmosphere around the treatment, and indeed this context includes the physical qualities of medication, such as color, smell, and taste, the characteristics of the hospital room, the sight of all professionals and medical instruments, and the interaction between patient and doctor. So in the last 2 decades, the powerful influence of the context on pain and analgesia has been investigated by using placebo effect as a model. And today in my talk, I'm focused the attention on some of the approaches, experimental approaches and models that have helped to better understanding the mechanisms underpinning these processes, with a particular emphasis on the neurobiology. If a placebo is given in a positive context, for example, along with the verbal suggestions of pain release, a placebo analgesic response can occur. At least 2 mechanisms create a positive context for the therapeutic outcome. The first one is a conscious mechanism, and it involves positive expectations, whereby positive contextual elements forecasting benefits may either reduce anxiety and activate reward. The second mechanism is an unconscious one, and it involves classical conditioning, the learning processes which has already been explained by my colleagues before. So context-induced positive expectations and context-induced classical conditioning produce brain changes that are associated with the activation of at least 2 neurochemical systems, the endogenous opioid systems and the endocannabinoid systems. The differential activation of these 2 systems takes place in different subcontexts. If a placebo is given before a pharmacological pre-exposure to mu-opioid receptor agonists, the placebo analgesic response is mediated by mu-opioid receptors. Whereas if a placebo is given after non-steroidal anti-inflammatory drugs, the placebo analgesic response is mediated by CB1 cannabinoid receptors. From a neuroanatomical viewpoint, there is now agreement that the administration of a placebo, along with positive verbal suggestions, activate a descending pain modulating network, which has a crucial role in modulation of the ascending nociceptive inputs. 3 important regions of the brain are involved in this network: the dorsolateral prefrontal cortex, the rostral anterior cingulate cortex, and the periaqueductal gray. Dopamine has also a role in placebo responsiveness, which depends, at least in part, from the function and efficiency of the reward circuitry. Indeed, the dopamine system in the nucleus accumbens is activated during placebo analgesic response. If a placebo is given in a negative context, for example, along with a negative verbal suggestion, a nocebo hyperalgesic response occurs, where hyperalgesic response means an increased sensitivity to pain. For example, negative diagnosis and prognosis can lead to an amplification of pain intensity and can have an important effect on the emotional state of patients. Nocebo and nocebo-related effects can also occur when patients distrust medical personnel or prescribed therapy. In health reports issued in Western society, nocebo effect can occur too. Indeed, negative warnings sent out by the mass media may have important impact on people's perceived symptoms. Headaches, for example, can be caused by believing that there are health risks associated with the use of mobile phone. And finally, in the field of clinical practice, communicating the potential adverse events of prescribed medication to the patient control group may induce the same adverse events of medication against which the placebo is compared. Mainly due to ethical limitation, less is known about the neurobiology of nocebo hyperalgesia compared to placebo analgesia. Indeed, inducing placebo responses is often acceptable, whereas inducing placebo responses is not, because of the anxiogenic nature of the process. From a pharmacological viewpoint, the nocebo hyperalgesic effect is mediated by cholecystokinin, CCK, and can be blocked by the problimid, which is the CCK antagonist, and can be blocked also by the anti-anxiety drug diazepam, suggesting that anticipatory anxiety induced by negative expectation have an important role in nocebo hyperalgesia. Nocebo hyperalgesic effects are also associated with a decrease of opioid and dopamine activation in the nuclear accumbens, highlighting the role of reward and motivational circuits in nocebo responses. Neuroimaging studies have also found that hyperalgesic effects, apart from hyperalgesic effect, negative expectation can induce the activity of brain regions including in pain processing and emotional regulations, including, as you can see here, prefrontal cortex, anterior cingulate cortex, and insula. Nocebos have also found to affect dorsal horn of spinal cord, thus interacting at the very early stage of nociception. Stepping into the meaningful context, the first thing to say is that contextual factors may have special symbolic meaning that powerfully influence the pain experience. For example, cancer-related pain can be perceived as more unpleasant than postoperative pain because of the association between illness, prognosis, and death on one end, and healing on the other, respectively. In a study of hand holding, married women were subjected to threat of electric shock while holding their husband's hand, the hand of an anonymous male experimenter, and no hand at all. And the authors found that the spouse's hand decreased the unpleasantness, the feeling of unpleasantness compared to no hand holding, whereas the strangest man had no such benefit. In addition, when women hold their husband's hands, brain imaging show an attenuated activation of neural systems that support emotional and behavioral responses to threats. As these pictures shows in green the attenuated activation of these regions concerned: right dorsolateral prefrontal cortex, left caudate nuclear accumbens, and superior colliculus. Interestingly, the effect of spousal and holding on the neural responses to threat also varied as a function of marital quality, according to the rule that higher the marital quality and the more attenuated the activation in these regions here highlighted in green. In order to better understand the neurobiologic effect of different meaningful contexts, some studies manipulated the patient interpretations of the meaning of pain. For example, Lickness and colleagues, in a study of pain perception, skin conductance, and brain activation response, pattern of responses to moderate pain, uses two different contexts for the analysis. Control context participants had 50% chance of receiving moderate painful stimulation or non-painful warm stimulation, whereas relative relief context participants had a 50% chance of receiving moderate or highly painful stimulation. Moderate pain was unpleasant and elicited negative feelings in the control context, which means when it was perceived as the worst outcome, because moderate pain is worse than no pain. Instead, moderate pain was perceived as surprisingly pleasant in the relative relief context, which means when it was perceived as the best outcome, because moderate pain is better than severe pain. In particular, in the relative relief context, moderate pain was similar in magnitude to the non-painful stimulation of the controlled context. And moreover, when moderate pain was perceived as pleasant, the activity in the nuclear accumbens was surprisingly increased. This study shows that even pain can be perceived as a pleasant experience if it is presented within a context with a particular and special positive meaning. Relief from pain can certainly be considered a form of reward, and effectively the relationship between pain and reward is well documented, as you can see here. Also, several studies have found that endogenous opioid and cannabinoids are both located in brain regions involved in pain and reward, and they overlap in neural processes, in processing of antinociception and reward behavior. The crucial role of expectations in the outcome of an analgesic treatment is highlighted by the decrease of its effectiveness if the meaningful context is eliminated. This involves to give an analgesic covertly so that the patient is unaware that a drug is being injected. This is technically called hidden administration, and it consists in delivering drugs at the desired time by a pre-imposed and computer-controlled infusion pump. By contrast, an open administration represented the routine medical practice, whereby the drugs are given overtly and the patient expects a clinical benefit. Bellint and colleagues studied open and hidden administration of a painkiller in combination with neuroimaging. When patients were told that they were receiving an analgesic, an opioid agonist, remifentanil, there was an amplification of the hyperalgesic effect respected to patients who had no expectation of pain relief because they were told that they were receiving saline, but actually they were receiving remifentanil. In addition, when patients were told that their treatment was being interrupted, but actually it was continued on remifentanil, the analgesic property of the drug was abolished. The neuroimaging studies of the brain activity of these patients show that The enhancement of analgesia induced by positive expectation was associated with the activity in dorsolateral prefrontal cortex and pregenual anterior cingulate cortex, whereas negative expectation induced by interruption was associated with activity in the hippocampus. The fact that hidden administration of a drug is less effective than its open administrations suggests that a drug can have a different action in the absence of expectations. Indeed, we know that the overall effect of a drug derives from its specific pharmacodynamic action plus the psychobiological effect produced by its administration. Atlas and colleagues in an article published on Journal of Neuroscience in 2012 suggested that these two components, drugs and expectations, operate independently from each other. Although drugs and expectation uses the same types of receptors, such as the mu-opioid receptors, these biochemical pathways are likely to be independent and located in different areas of the brain. So, concluding, at present it's possible to declare that if on one hand, different contexts can alternatively activate different neurochemical systems, on the other hand, the context itself is amenable to manipulation in order to therapeutically benefit the patients. As already emerged from the previous intervention of my colleagues within this topical seminar, in routine medical practice, special attention should be paid to those psychological factors that influence the symptomatology of pain, and these factors include emphasizing the importance of an empathetic relationship with patients, positive reinforcement during procedures, and the avoidance of communicating the adverse effects of prescribed medication. Challenges for future pain research are a better understanding of the endogenous antinociceptive and pronociceptive systems, and the identification of biochemical pathways responsible for drug effects and expectations effects, respectively. Thank you very much for your attention, and special thanks are extended to my mentor Fabrizio Benedetti and to all my colleagues from the neuroscience and psychology departments of the University of Turin Medical School. I also want to thank Giancarlo Quarta Foundation, which has been supporting my research, and also a special thanks to Regine Klinker and Sarah Camping for inviting me to join this topical seminar. Thank you.